So we can begin, and let me welcome everybody. And like I told you, Hitesh, this particular talk is aimed at anybody who's interested in osteosarcoma, to tell them everything that they need to know about osteosarcoma. So it can help the postgraduates, and it can help the specialty students as well. And the whole idea is that at the end of this talk, you should not require to go back to the books to really know the basics of osteosarcoma. But if somebody is interested in knowing a little more about this topic, then of course the books will come to your aid, or maybe you can ask the questions and we can talk to you. Another important thing is that this talk is not going to cover surgery. It's not going to cover surgical technique. It's going to tell you basic principles. And if the people or the students are interested in knowing about the principles of surgery for any malignant bone tumor, it doesn't apply only to osteosarcoma, then we can have a separate talk by itself. But this particular talk is aimed at anybody who's interested in osteosarcoma, and they don't have to be surgeons. They could be medical oncologists, they could be pathologists, or anybody who's interested in this topic and wants to update their knowledge. This is what will help them. So let's move on to what is an osteosarcoma. So by definition, osteosarcoma is a primary malignant bone tumor. When we say primary, means it is something which arises from within the bone. And the hallmark of an osteosarcoma is that the malignant cells will produce what is called as the malignant osteoid. So it's a matrix producing tumor. Unlike an Ewing sarcoma, which doesn't have any matrix, osteosarcoma produces an osteoid matrix. So it's the most common malignant primary bone tumor. So if you look at all the bone tumors, which are even otherwise rare, among all the bone tumors, osteosarcoma is the most common, followed by all the other tumors depending on the age. So you would get Ewing sarcoma in children, and you would get chondrosarcomas in adults. But osteosarcoma still remains the most common tumor. And the way to diagnose or to make the diagnosis is on biopsy or on histology, to see that you get osteoid, which is this pinkish material which you can see on the slide. This osteoid is produced by the malignant cells which are bordering it. And it is important for the pathologists, and they always see that there are no normal osteoblasts intervening between the malignant cells and the osteoid. And that tells you that the osteoid is coming from the malignant cells, as you can see in this histological picture. Now, this is the very basic histology, which is enough to confirm the diagnosis of osteosarcoma. But we all know that because this is a very high-grade tumor usually, and because it can multiply, or it may not be very well differentiated, or it could differentiate into various kinds of tissue. So you could see cartilage, you could see fibrous tissue, you could see vascular tissue, and sometimes you can see sheets of round cells. And I'll just tell you about the various varieties of osteosarcoma that can come. So classification of osteosarcoma has been very confusing for most people because there are so many different varieties. And after so many years, I think this is what I find to be the simplest way of understanding osteosarcoma. So we classify osteosarcoma depending on where they arise from. So you can say they are either intramedullary or they are surface osteosarcomas. And this, what we are talking of, are primary osteosarcomas. There's a whole group called as secondary osteosarcomas, which we'll discuss subsequently. But let's look at just the primary osteosarcomas. The most common primary osteosarcoma is a high-grade osteosarcoma, which arises from the medullary area. So it arises from within the bone. It is high-grade, and it by itself is also classified into various subtypes depending on histology, like chondroblastic, fibroblastic, etc. But again, we will discuss what is the importance or the relevance of seeing these different histologies shortly. The other variety of intramedullary osteosarcoma, which is rare, is a low-grade osteosarcoma. And again, I will discuss it subsequently after we have finished discussing the high-grade osteosarcoma. The other rarer tumor of osteosarcoma is something which comes from the surface of bone rather than from inside the bone. And there are 4 different types of those, and those also we will discuss each one of them separately. They are just about 5% of all osteosarcoma compared to the intramedullary, which is 95%. And importantly, most of the surface tumors are actually low grade, but there are a few surface tumors which are high grade. For example, the high grade surface and the dedifferentiated, which are as high grade as the conventional intramedullary high grade osteosarcoma. Now, the incidence of osteosarcoma is about 3 to 5 per million population between the age of 0 and 24 years. Now, why we say this specifically is because osteosarcoma is pretty rare after the age of 24, and most of the cases would happen in this age group. So depending on the country's population demography, every nation can calculate how many osteosarcoma cases they expect to see annually. And this doesn't change from region to region. This remains the same, whether it is Europe, United States, anywhere in Asia. The usual incidence is between 3 and 5, and most of the time we say it's about 4 or 4.4 in the age group of between 10 and 19, which is the commonest age at which you get an osteosarcoma. It comprises about 3 to 5% of childhood cancer, and because it happens more often in children, it's one of the more important varieties of childhood cancer. As I told you, the commonest age is between 10 and 25 years of age, which is the second decade of life or adolescence. And probably because this is the time when the body is undergoing the fastest growth. And that's when probably something triggers the development of osteosarcoma as what is thought to be the etiology. Males are slightly more often affected than females. As you can see, the ratio is about 1.4:1. And because the largest joint or the largest amount of bone and growth occurs around the knee, it is not surprising that 70% of osteosarcomas actually happen around the knee. Now, if you look at the difference between Asia and all other countries, you'll realize that we don't see a second peak. And we've seen this in India as well. For long, we have learned from the Western literature that a second peak comes between 60 and 70 years of age. And that is because they have secondary osteosarcoma arising on a background of Paget's, etc., which for some reason is not seen in India or in the other Asian countries. We don't really know what is the cause of that, but I think it's good that we don't see it, because these secondary osteosarcomas are very, very difficult to treat, unlike the primary osteosarcomas, which have very good treatment and very good cure rates. Now, coming to the histological subtypes, as we know, the commonest thing that we know about, or the typical osteosarcoma, is an osteoblastic osteosarcoma because it forms bone. It forms osteoid, which gets mineralized, and therefore we call it as an osteoblastic osteosarcoma. But depending on which component is more prominent, you can classify these osteosarcomas into chondroblastic, fibroblastic, telangiectatic, or small cell osteosarcoma or round cell osteosarcoma. Lately, there is another entity which has been recognized called as a giant cell rich osteosarcoma, which again is something to know. What is important is, though you can give these histological subtypes, these are not important because none of them have been shown to have any different prognosis. What is just important to know is some of these can be a diagnostic dilemma. For example, if you just see the small cell osteosarcoma, if you see the histology, it may look like Ewing sarcoma, particularly if you have a needle biopsy when the amount of tissue is small or the sample is small. You may not always see osteoid, and a wrong diagnosis can sometimes be made. But that's not so much of a problem, because very often the same drugs are used also for the treatment of Ewing's. And we have seen that where the diagnosis has been mistaken and the Ewing's therapy has been started, these patients have still responded to the chemotherapy. The problem actually is the giant cell rich osteosarcoma. And if the pathologist is not experienced and passes this off as a giant cell tumor, then a huge mistake can be made. We have to understand that the neoplastic component of even a giant cell tumor is not the giant cells, but the spindle cells. And if the spindle cells are malignant, then it's a giant cell rich osteosarcoma and not a giant cell tumor. And that's the reason why we always say that the pathology has to be done by a pathologist who's experienced in these tumors. Otherwise, the chance of making a mistake is huge, particularly on needle biopsies. Now, telangiectatic osteosarcoma deserves a special mention because it can often look like an aneurysmal bone cyst. You can see in this patient of a proximal humerus osteosarcoma that the humerus is blown out, it is expanded, and even if you look at the MR, you see multiple fluid levels. The trick here is to look for some subtle signs. If you look, you can see actually some kind of a osteosarcoma. You can see bone formation, you can see, which you don't see in APC. And if you do a contrast enhanced study of the MR, you will find nodular enhancement, as you can see in these cases. And that gives you the diagnosis. You have to direct the biopsy into those areas which are showing enhancement. Otherwise, it may be difficult to pick up the osteosarcoma cells and make the diagnosis. Now, coming back to the types of osteosarcoma, as we have discussed, broadly, you've got a high-grade variety and you've got a low-grade variety. And I think everybody knows the difference between that. The high-grade varieties multiply or grow much faster and metastasize quicker compared to the low-grade varieties, which grow slowly and take a long time before they actually metastasize. So the pathologist is able to tell you whether this is high-grade or low-grade, but most conventional osteosarcoma is a high-grade osteosarcoma. And osteosarcoma, though classically described, has been bone forming. One has to remember what tuberculosis is to all orthopedic conditions. That is what osteosarcoma is to all tumors. It can look like anything. So it can be extremely osteoblastic, as you can see in this tibial case, or it can be completely lytic, as you can see in this distal femur case here. And sometimes it can look telangiectatic, it can look like an ABC, it can look permeative, it can look moth-eaten. So there is no classic appearance, or there is no appearance which can tell you that this is not an osteosarcoma. So in the age group of 10 to 25, it should always be a part of differential diagnosis, irrespective of what the X-ray looks like. Now, we all think that osteosarcoma is known to come in the metaphysis. And yes, a large numbers will come in the metaphysis, but 9% of all osteosarcomas will come in the shaft or in the diaphysis. And there it can show you a lamellated periosteal reaction, and it can look exactly like an Ewing sarcoma. And therefore, if you see any malignant tumor in the shaft of any of the long bone, remember that it can't be just Ewing's. We always keep even osteosarcoma as a differential diagnosis, particularly if it is in the age group of between 10 and 25. Now, a low-grade osteosarcoma is rare, as we said, and the trick to making a diagnosis is from history. So this particular man, you can see with a large swelling, when we asked him how long it has been there, he said it has been there for 5 years. And a conventional osteosarcoma is not going to stay for 5 years because it is so high grade that it would have metastasized and killed the patient within 2 to 3 years. It is very rare that a high grade osteosarcoma without treatment will survive longer than that. So if you have a long history, we must think of a low grade osteosarcoma, and we should understand that while low grade osteosarcomas are relatively good, in the sense is that they will not metastasize, they don't need chemotherapy. If you leave them long enough, they can de-differentiate. Or if somebody does an inadvertent surgery, for example, this particular patient had a surgery where somebody thought it's a myositis mass and tried to remove it, and then it came back. So with a recurrence, an osteosarcoma, a low-grade osteosarcoma can de-differentiate. And once de-differentiated, these are some of the worst tumors one can get to see because they don't respond much then to any kind of chemotherapy or treatment. And very often they will lead to a metastatic disease and death. Now let's look at the surface osteosarcomas, which, as I told you before, They form only 5% of all osteosarcomas, and they are divided into the commonest variety, which is the parosteal osteosarcoma. We'll talk about each of these varieties separately. So the parosteal osteosarcoma classically arises on the back of the femur, which is the common site, but even the tibia is a common site. You can sometimes see it in the humerus, and actually it can be seen on the other bones as well, though it's a little rare. The trick to the diagnosis is that it looks like a blob of bone which is stuck onto the surface of bone. And you can see what is called as a rope sign, which means that there is an interval between this blob of bone which is stuck on and the actual cortex of the femur. But you will find that there are areas where you cannot separate it out. It doesn't separate out from the bone because it arises from the surface of the bone. If one does a biopsy, there are times when the pathologist may find it very difficult to give you the diagnosis because you can see mature cells which may not look very malignant. And unless you look at the radiology and pathology together, it is sometimes difficult to make a diagnosis. So parosteal osteosarcoma is a diagnosis primarily based on radiology, but you confirm it by doing a biopsy. You have a very interesting and a rare variety of a surface tumor called as a periosteal osteosarcoma. Now, the diagnostic feature of this, if you look at this X-ray of the tibia, is you see scalloping of the bone, and you find what is called as streaking at 90 degrees to the cortex of the bone. So you find bone which is laid down along the vascular channels, and this is, if you biopsy, looks like cartilage. It looks like a chondrosarcoma. In fact, you don't see anything else but chondroid tissue, and that's the hallmark. We have to remember that the age group of a chondrosarcoma and a periosteal osteosarcoma is completely different, plus the radiological features are completely different. This is on the surface of bone, whereas a chondrosarcoma most often is inside the bone. So I think when you combine radiology and pathology, you will not make a mistake between a chondrosarcoma and a periosteal osteosarcoma. Now, periosteal osteosarcomas in grade are classified as intermediate between a high grade and low grade. There is no consensus as to whether they should get chemotherapy. Most centers around the world don't use chemotherapy for a periosteal osteosarcoma. So it's important to recognize it from the characteristic radiological appearance. And when you do a pathology, when you do a biopsy, you will find chondroblastic tissue. And that's how you can make a diagnosis. This is another example of a periosteal osteosarcoma. You can again see here, you can see that linear streaking where bone is formed along the blood vessels, and you can see the scalloping of bone. These are characteristic radiological signs of a periosteal osteosarcoma. A high-grade surface osteosarcoma is a very rare tumor, but any surface tumor can be a high-grade tumor. You can see that this looks like a bone-forming tumor on the surface. One may think that this is low-grade, but if the history is gone into, it will be a rapidly growing tumor, and the histology will be diagnostic. It looks identical to what you would see with a conventional intramedullary high-grade osteosarcoma. The treatment of a high-grade surface osteosarcoma is exactly identical to that of a conventional high-grade osteosarcoma. So this is an example again of an osteosarcoma which has been excised. The previous one which I showed you, this X-ray, and this is the one which has been resected and reconstructed. This is another conventional high-grade osteosarcoma. If you see carefully, sometimes you may think that this is a low-grade or a periosteal osteosarcoma. But when we did the pathology, it was not chondroblastic, it was a conventional high-grade osteosarcoma. A dedifferentiated parosteal osteosarcoma is another high-grade surface osteosarcoma. So if a parosteal has remained for a long time, or if again, like a low-grade osteosarcoma, it has been resected, somebody has removed it and not removed it completely, and it recurs, you can get a dedifferentiation. And this dedifferentiation is sometimes difficult to spot unless there is a history of rapid growth. And these tumors, again, are to be treated like any other high-grade osteosarcoma. The prognosis is not always good. They don't always respond well to chemotherapy, but the treatment is going to be chemotherapy and surgery for these tumors. So let's look at the real differences between parosteal, periosteal, and high-grade. One is the radiology. The parosteal is the commonest, followed by the periosteal. And you can see that the lowest grade is that of a parosteal with the best prognosis and the highest cure rate. The sites which affect are more or less similar. They're more common in the femur and the tibia. And the mortality, as expected from the grade, is the lowest with parosteal and the highest with a high-grade surface osteosarcoma. Now, we spoke about a secondary osteosarcoma, which we don't see very commonly in India, but is commonly seen in the West when you have an osteosarcoma arising on the background of a previous bone disorder like a bone disease, like an infarct. You can sometimes get it from fibrous dysplasia. These tumors, again, come in the old age. They come between 60 and 70 years of age, and they're very extremely high grade. One reason for getting a secondary osteosarcoma is actually radiation to a diseased bone. So this is an example where you can see that this was a giant cell tumor which was radiated in 1988. And this, I will show you pictures, subsequently went on to develop a radiation-induced sarcoma, osteosarcoma. Now we know that any radiation, which is an orthovoltage radiation with more than 4,000 rads, risks development of an radiation-induced osteosarcoma. So you can see in these pictures that many years later, after 1988, when she was radiated, almost 13 years later, she came with swelling, pain, and at that time, the MRI showed a new mass, and this was a radiation-induced osteosarcoma. Radiation-induced osteosarcoma is again extremely high grade, does not respond usually to chemotherapy, and will metastasize in almost 70 to 80% of the cases. This is an example of an Ewing sarcoma. In August 98, was treated with chemotherapy, was treated with radiation. It seemed to have healed well, and then developed a secondary osteosarcoma. Now, there are two conditions which are actually benign, but which can be easily confused with an osteosarcoma. One of them is a stress fracture, as you can see in this picture. If you do MRIs and particularly CTs, you will be able to recognize the stress fracture, and then there is no difficulty in diagnosis. But if somebody doesn't recognize that and takes a biopsy, then sometimes the pathologist may find it very difficult to make a diagnosis of a stress fracture rather than calling it as an osteosarcoma, because the cells in an acute fracture can be rapidly multiplying and can look bizarre. Similarly, myositis is another condition which can be mistaken for an osteosarcoma. And these are the two places where we again say that you need a skilled musculoskeletal pathologist to give you a correct diagnosis and not to have a mistake. And therefore, anytime we have a case which is difficult, or preferably any malignant tumor, I think you should get or send a sample of the biopsy to the best available pathologist who has the experience, so that people don't make a mistake in diagnosis. Particularly, this particular dilemmas can be resolved only at a good oncology centers, and therefore we should not hesitate to send them over. We have seen many cases. I have seen quite a few cases which have been mistakenly amputated by people who believed the pathologist's report. And when we went back and reviewed the slides, they were actually myositis. And this is probably the worst thing that can happen. Now, there's another thing which is often confused because of its name, and that's an extraskeletal osteosarcoma. Extraskeletal osteosarcoma means that this is an osteosarcoma arising in the soft tissues and not attached to the bone, or not arising inside the bone. Now, we must understand that these are actually not osteosarcomas at all. They are high-grade soft tissue sarcomas which form bone, and that's why they are called osteosarcomas. And they are to be treated like any other high-grade soft tissue sarcoma. They don't respond to the osteogenic sarcoma chemotherapy, and there's no evidence that they benefit from this chemotherapy. So they're treated with the same principles as a soft tissue sarcoma. They require a wide excision coupled with radiation. Now, what is the real cause of an osteosarcoma? We know that Ewing sarcoma has specific mutations which may be the driver for developing the malignancy. But we know that in osteosarcoma, in most of the cases, we don't find any specific mutation or a constant mutation. We don't actually know what causes or triggers the osteosarcoma, but we suspect that it is something to do with the rapid growth phase, because initially it was believed that people who are taller would have a higher risk, but this has not been borne out on epidemiological studies. There are certain germline mutations in the RB gene or in the P53, which can put the patient at a higher risk of developing an osteosarcoma, particularly if they receive radiation for any cause. But otherwise, I don't think we still know what is the true etiology of an osteosarcoma. Now, that's about understanding the various types of osteosarcoma and the various classifications. And now we can move on to how do we actually manage a patient with an osteosarcoma. So whenever somebody comes in the right age group with a swelling or a tumor on the leg, the first thing as clinicians, I think, is we form a image in our mind, and we try to think of whether something is easily salvageable in terms of doing a limb salvage surgery, or is it borderline, or is it clearly not salvageable. This is sometimes important because there are people who come with very big disease and who come with pathological fractures, who are in extreme pain and may require upfront surgery in the form of an amputation rather than chemotherapy first followed by an amputation. But most people, almost 90% of osteosarcoma cases, are the ones where our final decision whether we'll do a limb saving surgery or not will be made only after we have started the chemotherapy. And despite what our clinical impression is, we have to do a full workup to first make a diagnosis, then do a staging in terms of metastatic workup, and then decide what is going to be the final treatment for this patient. So we begin with X-rays. And as I told you, you will see a large number of different presentations or pictures or appearances with osteosarcoma. So this is what is the classic. Here, there's no differential diagnosis. And if any student calls this anything other than an osteosarcoma, he's likely to fail. Or if he doesn't call this as an osteosarcoma, then he's likely to fail. I think this is a spot diagnosis, and there is no other difference. The situation is different when you don't see the classical features. So you can see the first image of the femur. You can see it's a lytic lesion. Looks like a non-ossifying fibroma, but this is actually a high-grade osteosarcoma. You can see the middle picture with the tibial lesion that looks like it's something on the surface, but it was actually a high-grade intramedullary osteosarcoma. Again, you can see in the femur, there is some bone formation. You can see something like a hair on end periosteal reaction, permeative appearance, more typical of an Ewing sarcoma, but is actually a high-grade osteosarcoma, as you can see in these pictures. You can also see pathological fractures through lytic areas and bone formation. You can see atypical sites like the radius, where mostly generally you see giant cell tumors, but you can occasionally see osteosarcomas arising at this site as well. In the pelvis, sometimes the lesions are obvious, where you can see in this first picture on the left, we can see clearly a bone-forming tumor from the ileum. In other areas, it may be purely osteolytic and very difficult to make a diagnosis, as you can see in the picture, in the X-ray picture on the right, in the pubic ramus. This is also a high-grade conventional osteosarcoma. So once you have the X-rays, then you have to decide what more you need to do. So the moment we are suspecting any malignant tumor, not just osteosarcomas, one would get an MRI done. Now, when we order an MRI, it is extremely important to order correctly. We don't say MRI of the knee, because then they will not image anything beyond a few inches from the knee. Only the classic knee sequences are done. The T2 sequences are not done. Contrast is not given, and therefore a lot of things can be missed. So if you're suspecting a tumor, we don't say MRI of the knee. We say MRI of the distal femur with screening of the entire femur with contrast. So you can see in these images, you can see skips which the MRI can pick up. You can see in this picture down in the proximal femur, the skip which would have been missed if the entire bone was not covered. So an MRI will give you information not just about the local extent of the disease and the relationship of the neurovascular bundle, but will also tell you about the skips which you can see in the same bone. It tells you the extent within the bone. It tells you what kind of resection you are going to need and allows you to plan a limb saving surgery. In many of the cases, it also tells you what would be the best area to biopsy, and therefore an MRI should be done before we do a biopsy rather than after we do a biopsy. Now, having done the local imaging, we also need to know if the disease is local or it is metastatic. So in effect, there are only two stages of any osteosarcoma. So osteosarcoma is either localized or it is metastatic. And the commonest areas where osteosarcoma metastasizes are the lungs, and that which is 95% of the metastatic disease happens in the lungs, and 5% happens in the bone. Any other site like the lymph nodes or any other areas is exceedingly rare and is not specifically generally looked for. So it's very unusual to get a lymph node mets, although we see sometimes. But so the protocol involved with staging, a standard protocol is getting a bone scan done, which will tell you whether there are any additional bony sites, and also getting an X-ray chest and also a CT scan of the chest. Now, you see that X-rays can be osteolytic, you can see osteoblastic, you can see fractures. MRI will give you the extent, it tells you whether the joint is involved, not involved, how far the neurovascular bundle is, and you can see the skips. You can see how the MRI has identified the skip, and you can see a specimen alongside it, and that's the skip. A bone scan will pick up generally any skip, or it can also pick up mets. You can see in this particular case, there's a skip right above the distal femur tumor, which is hot. And if you look carefully, there is also a metastatic disease in the finger, which is again a rare site. And when we did the X-ray, it was actually picked up. This is a multicentric osteosarcoma, and you can see picked up on the bone scan. It's multiple sites and corroborated by the X-rays that we see. So there are many sites which you see. It's important to recognize the multicentric osteosarcoma because again, these are very bad diseases, and almost all patients, in fact, all patients will die. There's really no cure for a multicentric osteosarcoma. Now, coming back to the chest imaging, there's often a confusion as to what kind of a CT scan of the chest do we do, and why do we need a CT scan in the first place? So to answer the second question first, we need a CT scan because a chest X-ray will detect a metastatic nodule only if it is more than 8 millimeters in diameter, whereas a CT scan can pick up lesions which are as small as 2 millimeters. And it is important to know that the disease is metastatic or not because the prognosis changes. A non-metastatic osteosarcoma has anywhere between a 65 to 70% chance of being cured, whereas a metastatic osteosarcoma, this chance falls to less than half. Now, we don't need an HRCT. What we require is a simple spiral CT. We don't require contrast. We just require 2 mm contiguous slices. So this is something which is enough for screening for mets of an osteosarcoma. One more thing to remember is small sub-centimeter lung nodules are quite commonly picked up in countries like India. And if you see them, we have to note them and we have to observe them. If any of these nodules increase in size, then they become suspicious for disease, and then they would require a biopsy. Also important to remember that any nodule less than 6 or 7 mm in diameter is extremely difficult to target and biopsy. And therefore, we generally do not biopsy these lesions unless they're at least 6 to 7 millimeters in size. A lot of people have asked about what is the role of a PET-CT in the diagnostic workup of an osteosarcoma. And as of today, it's still not a part of the absolute must in the guideline. But we all do a PET-CT because we find that it is extremely useful, not just to pick up atypical sites which are rare, but more importantly, to pick up the response to chemotherapy. Which means that if we do a PET-CT prior to starting the chemotherapy, and if we do it again after the induction chemotherapy prior to surgery, it is possible to pick up the response to chemotherapy which matches accurately with what the histology says. Now, this may be important in borderline cases where to do a limb salvage, we may have to compromise some of the margins and accept narrower margins. And it would not be safe to accept these narrow margins unless and until the patient has shown a good response to chemo. So while it's good, and if it is possible to get it, we should do it. Again, important to remember that when we ask for a PET-CT should always be combined with a breath hold CT of the thorax, as we have discussed in the previous case. So in a single imaging, then we can do it. Then we don't need to do a bone scan or a separate CT scan chest afterwards. This is an example of a distal femur osteosarcoma. You can see on the left the pre-chemo PET image, and on the right you see a post-chemo image. You can see that the metabolic activity is reduced. One has to understand that in osteosarcoma, because it produces matrix, the size of the tumor does not reduce, but the metabolic activity can reduce. And an X-ray or an MRI may not give an idea about the response to chemotherapy, but a PET-CT is extremely useful because when you find that the SUV max values, which are used to indicate to us the metabolic activity, have fallen to more than 50%, we know that this patient has an extremely good response to chemotherapy, as in this case. On the other hand, if there are times when after chemotherapy, the size of the tumor increases. And this can happen because the tumor has become necrotic. Because it has become necrotic and liquefied, the volume can actually increase. But that does not mean the patient has not responded. In fact, it can happen when the patient has responded. So a PET-CT can actually tell us what is the true situation. You can see in this particular case that there is an increase in the volume and the metabolic activity. So this is a patient who has actually progressed on chemotherapy. And this is a particularly bad prognostic sign because, again, these patients who don't respond or who progress on chemotherapy actually do not have a good survival. Now, we've discussed a lot about X-rays, MRIs, the typical appearances, but extremely important to know that irrespective of how typical the appearance is, in spite of the fact this is a classic osteoblastic osteosarcoma, we still have to do a biopsy. It is important to establish the diagnosis on the biopsy because it's medico-legally required. And secondly, the patient may respond so well to chemotherapy that if you try to remove the specimen afterwards and then do the pathology, you may not find any viable tumor. We've had cases where the patient may then blame the surgeon that you operated wrongly because there was no tumor in the first place. So it's very, very important to establish. Remember that unless you have a complete diagnosis, a confirmed, confident diagnosis of an osteosarcoma, we don't start a patient on the treatment for osteosarcoma. In current world, we don't do open biopsies at all because open biopsies are dangerous. They're associated with lots of complications, and I'll show you pictures of that. And most often, needle biopsy in more than 95% of the cases will give us a diagnosis. So we use a Jamshedi needle. 3 cores are generally enough, and that establishes the diagnosis. Now, why do we insist that we must have a biopsy? Now, if even if the appearance is typical, yes, but what if it looks like something benign? You can see here, each and every radiologist thought, including the surgeons thought this is an aneurysmal bone cyst, which you can see here, fluid levels. But the biopsy showed that this is a conventional high-grade osteosarcoma, and therefore no damage was done, and doing a biopsy as a rule helped us avoid an embarrassing situation when this tumor would have been curated on the assumption of an aneurysmal bone cyst, and then things would have got complicated for a limb-saving surgery. So it's a good idea to biopsy every lesion before you assume a diagnosis. If you have to assume a diagnosis, better to assume it is malignant rather than to assume it is benign. Now, this is another case. You can see it to us look like an osteosarcoma because it is sclerotic, it is permeative, there's a soft tissue mass, but the biopsy showed us that this was actually tuberculosis. So this was tuberculosis masquerading as an osteosarcoma. So again, important that the biopsy established a diagnosis because our treatment becomes completely different. Now, why do we say we don't want to do an open biopsy? Because if you're planning a limb salvage surgery, as is the usual plan in an overwhelming majority in more than 90% of our cases, you will see that the amount of the tract which needs to be excised with a needle biopsy is very small, as you can see in this lower picture. What you see in the upper picture is a very well done biopsy, but even after that, you can see that you need to remove a significant amount of skin and the underlying tissue. And this can sometimes create challenges for closure after limb salvage surgery. So it's best to do a needle biopsy because most often this can be done as an outpatient procedure, and it's safe, it is simple, it doesn't require any major admission, hospitalization, anesthesia, and most often you will get a diagnosis in more than 95% of the cases. So it's very easy today to recommend that we should only be doing needle biopsies and not open biopsies. This is an example of some of the cases that we have seen where a bad open biopsy actually created complications in doing a limb salvage surgery, or actually made us do, in the lower two cases, you can see that it made us do an amputation because of a badly done biopsy. And this is not infrequent. And therefore, if you think that you need an open biopsy, I think the patient has to be referred to a tumor treatment center so that they can get the right job done. It's not fair in today's world when osteosarcoma has a 90% limb salvage rate and a 70% cure rate to compromises these chances for the patient, where just because somebody who doesn't know what to do has done an open biopsy. So we say no open biopsies by anybody except by the team which is going to do the final procedure. Now let's understand the treatment. Now to understand the treatment, we must understand that for a long time, there was actually no treatment for osteosarcoma. In fact, people used to say that osteosarcoma is a death sentence. And I remember that in 1994, when I joined as a fellow at Tata Memorial Hospital, whenever there used to be an osteosarcoma patient admitted, my boss used to look at his lifeline because everybody knew that this patient is not going to survive. Even in 1994 in India, chemotherapy was not done frequently. Very few cases would get it. And what changed this, all these statistics was the advent of chemotherapy. Now completely, there was a reversal of the survival rates, because originally only 15 to 20% of the people would survive, or osteosarcoma patients would survive even after a major amputation. But after chemotherapy started, the 2-year survival jumped up to almost 50 to 80%. And today the 5-year survival is probably about 60 to 70% on that. And what changed this treatment is the methotrexate. Now again, methotrexate is not a rare drug. It was in use for treating malignancies in the 1970s. But the doses that were used to treat, say, breast cancer were in milligrams, whereas the doses that are required for sarcomas to respond, particularly osteosarcoma to respond to methotrexate, is in grams, which means that 1,000 times the dose of the standard dose needed to treat the other cancers is what is required for sarcoma. You can see from this graph that the dose response curve is almost linear. You increase the dose and the response is better. So methotrexate in a dose of 6 to 8 grams per meter square is what is the dose required to have a response in osteosarcoma. So Jaffe in the 1970s at MD Anderson centers actually showed that osteosarcoma has responded to this kind of chemotherapy. Now we have other drugs as well. We've got adriamycin and we've got cisplatinum. These are two other drugs which have very good response rates in osteosarcoma. Ifosfamide is another drug which has been added and which also has a very good response rate in osteosarcoma. So very broadly, if you have to divide the chemotherapy protocols, there are multiple protocols existing in the world. Let's put it that there are two protocols. One is high dose methotrexate based protocols, which are called as MAP protocols because it is methotrexate, adriamycin, and cisplatinum. And the other protocols are non-methotrexate based, which will use ifosfamide instead of methotrexate. Now, it is not important to know the doses of the drugs except for those people who are going to do chemotherapy, but it is important to realize that these are high doses of drugs. And therefore, this chemotherapy is never done as an outpatient chemotherapy. It's generally done as in-house admitted patient chemotherapy, where the drugs are given with monitoring so that the patient does not develop any toxicity. With methotrexate levels are required at 24 hours, 48 and 72 hours, and that is what makes this treatment more difficult as well as expensive. But the responses to methotrexate are very good, and though short-term toxicities can happen, and that's why we do the levels, there are very few long-term side effects of methotrexate. Compared to ifosfamide, which is the alternative, it is cheaper, but ifosfamide can cause severe renal toxicity and can cause severe gonadal toxicity. In fact, in males, it almost results in permanent sterility or azoospermia in almost everybody. And therefore, our preferred protocol today would be something which would use methotrexate, but a lot of people who can't use it because of cost reasons would use ifosfamide instead of methotrexate. Now, the number of cycles of chemotherapy used before surgery varies from center to center. Overall, anywhere between 2 to 5 cycles of chemotherapy are done pre-surgery. We are now getting around to thinking that it should be less rather than more. So 2 to 3 cycles are generally what most centers use. And it's very common to get neutropenia following this kind of doses. So growth factors may be required. Patient may require readmission with febrile neutropenia, where they may be required to be given antibiotics and required to be monitored, because febrile neutropenia with counts going down to double digits, that means the WBC count goes down to double digits, is a dangerous situation. It's a life-threatening situation and requires immediate intervention. And therefore, again, this chemotherapy, just like surgery, has to be handled by medical oncologists who are experienced with this kind of chemotherapy rather than by just anybody who can do it. Even high-dose methotrexate requires understanding, requires some experience, requires monitoring, and cannot be taken lightly. Now, what does chemotherapy do? Chemotherapy, when you give it before surgery, first of all, starts your treatment immediately. There is no waiting time. Therefore, the moment you start the chemotherapy, you start attacking the tumor. Now, we know that by the time osteosarcoma has presented to the orthopedic surgeon, there are already lots of cells. There are millions of cells which are circulating in blood. You may not see them by the conventional imaging, which is available today, including a PET scan, but these are the cells which will cause metastatic disease and will appear later. What chemotherapy does is kill these circulating tumor cells, and therefore it improves the survival. So the main reason why the survival jumped after chemotherapy was because of its ability to control the micrometastatic disease. Now, it started initially being given before surgery because all the joints which were done for limb-saving surgery were customized, and it would take 6 weeks to fabricate these joints. And therefore, not to keep the patient waiting and allowing the disease to progress, the chemotherapy started giving chemotherapy before. And that's why it's called neoadjuvant chemotherapy, where some chemotherapy is given prior to surgery, then surgery is done, and then again the rest of the chemotherapy is done afterwards. The total number of cycles given are anywhere between 6 to 9 cycles. Generally, we use 6 cycles when it is a methotrexate-based protocol, because each cycle in the MAP protocol is about 5 weeks. So it's about 30 weeks of chemotherapy. If one uses only adriamycin, ifosfamide, and cisplatinum, then we give about 9 cycles of chemotherapy, because each cycle is only about 3 weeks. So it's about 27 weeks of chemotherapy. Now, we started neoadjuvant chemotherapy because of the necessity of buying time before surgery, but we realized that this is actually a good policy. It allows us to control the disease. It allows pathological fractures to heal. It allows a reactive zone to form around the tumor. You can see in these CT scans below of the distal femur that the tumor has got ossified and has become well marginated. So with a good response to chemotherapy, you realize that if the reactive zone becomes well marginated, the number of satellite lesions outside the marginal zone reduces, and therefore the risk of local recurrence reduces. Sometimes, therefore, especially around important structures like the neurovascular bundles, a smaller margin becomes acceptable just because we have chemotherapy which has controlled the tumor. Now, if you don't get a good response to chemotherapy, then the local recurrence rates are higher. And if a pathological fracture has actually not healed, then it may become a contraindication to doing a limb-saving surgery. In fact, if pathological fracture heals, then there is absolutely no reason not to do a limb-saving surgery. Therefore, pathological fractures are not an absolute contraindication. You give them chemotherapy, judge the response, and if they respond to chemotherapy, then they can be taken in for limb-saving surgery. Now, when we do the limb-saving surgery and we remove the specimen, we have to assess the response to chemotherapy. And the response to chemotherapy is assessed by what is called as Hughes grading. Now, this is a grade 1 to grade 4, where grade 4 is a complete necrosis. What is done to assess this necrosis is that you grid the specimen. So you section the specimen in the sagittal and the coronal planes, as you can see here. You divide them into blocks, and then you take sections from each block and calculate what is the percentage of cells which are living and what is the percentage of cells which are dead. Once you have that total number, then you say, so it's an extensive job for the pathologist to do this necrosis evaluation. Grade 4 means there is no viable osteosarcoma left in the specimen. This is the best possible response. About 10% of our patients have a grade 4 response, and these people, actually a grade 4 response is associated with much higher cure rates. Almost 90% of the patients who show a grade 4 response go on to become long-term survivors. On the other hand, grade 1 is where you have hardly any response to chemotherapy. Grade 2 is when you have more than 10% viable tumor. And grade 3 is when 90% of the tumor is dead and you have less than 10% of viable tumor. So grade 3 and grade 4 is considered as good responder, and grade 1 and 2 is considered as a poor responder. The survival of grade 3 and 4 is better, but it does not mean that grade 1 and grade 2 cannot be cured. So while you may have a poor response to chemotherapy, it does not mean the patient cannot be cured. And this is very important when we counsel the patient. So to sum up, what are the principles of chemotherapy? 3 drugs better than 2. You can use methotrexate, or you can use ifosfamide as one of the drugs. The adriamycin and cisplat is common between various protocols. The difference between these two protocols would be that the acute toxicity is more with methotrexate and permanent sterility is more of a problem with ifosfamide. Now, whether you start the chemotherapy neoadjuvant, that is before surgery, or whether you do it afterwards, does not affect survival, and this has been shown by randomized controlled trials. But in short, almost all of us, because of the obvious advantages which I've enumerated before, start the chemotherapy prior to surgery. Now, irrespective of what has been the response to chemotherapy, surgical resection remains almost the same. So we don't treat these by radiation, we treat these by surgery, because osteosarcoma is extremely radio resistant, unlike Ewing's, where radiation can be used. But even in Ewing's sarcoma, surgery is better than radiation. And we have to remove all the disease if we have to get a cure. So even if the patient has metastatic disease, for example, nodules in the lung, and it can be resected, the plan is made to remove even the metastatic disease. So we have to remove all existing disease, even though chemotherapy has been given. Now, what are the factors which are important in making a decision? So we look at whether the patient has localized or metastatic disease, because the prognosis is different. And this is important during counseling, because limb salvage can be expensive and it may involve multiple surgeries. And therefore, if the patient has metastatic disease and the family is unable to spend money on a limb salvage surgery, then it is better that the patient gets good chemotherapy, spends that money on chemotherapy rather than on limb salvage surgery, so that at least the survival is better. So we have to assess whether the patient can be offered limb salvage or not based on how much is the local extent. And we also have to look at the socioeconomic factors. It is important because if the patient has a limited amount of money and cannot arrange for limb salvage, it is better that that money, as I said, go to chemotherapy. We have to also understand that limb salvage can have its complications. Patient may require second surgery, sometimes third surgery and fourth surgery as well. And each of these things will add to the cost. Therefore, it's very important to counsel the patient that if they are opting for limb salvage, they must understand that they may require multiple surgeries, they may require revision surgeries in future, and that their costs are going to be higher than if an amputation is done. So after all this is taken into account, the patient is counseled, and then we start the treatment. Now, fortunately, in today's world, amputations are not done commonly. They're done generally only for patients who've got very large disease where we can't get proper margins or we can't get tumor-free margins, and therefore we have to do an amputation. Sometimes it happens because of bad surgery done or a bad open biopsy done. And these are sad cases, because you really feel bad for these patients. But sometimes you would do it just to relieve the patient because they have a very bad fungating disease, or they've got a pathological fracture which makes them very painful. And then you would go ahead and do an upfront amputation. Now, when we started doing limb salvage surgery, almost everybody had this doubt as to whether it would compromise the survival of the patient. So there have been several studies which you can see on this slide, which have compared the difference in survival between those who had limb salvage versus those who had an amputation. So if you look at these two graphs, which have analyzed the cases of distal femur osteosarcoma, where they've compared limb salvage and above knee amputation and hip disarticulation, you can see the three different curves. You can see that local recurrence does not happen with a hip disarticulation. The local recurrence rates with a limb salvage as well as with an above knee amputation are the same. But the survival is the same with all the three, which means that there is no advantage of doing a hip disarticulation for a distal femur osteosarcoma, because the survival does not change even though the local recurrence rates are higher. Now, the same thing applies even with a limb saving surgery. So if you do a limb saving surgery with proper margins, then there is no difference in outcome between an amputation and limb salvage surgery. The psychological benefits are very obvious and immense, and therefore we don't need a randomized trial to say that where the limb can be saved and the patient opts for it and wants it, we would do a limb saving surgery rather than an amputation. So the only prerequisites before we do a limb salvage surgery is our ability to get a wide margin and the fact that we must have adequate function of the salvaged limb. In India, it's also very important that the patient has received proper chemotherapy, because it is not enough, or it would be quite foolish to do a limb saving surgery without chemotherapy, because this patient is not going to survive. So life becomes more important than the limb. We have to very honestly tell this to the patient and make sure that they understand and choose their options carefully after counseling. Now, margins are very important. The margins have been prescribed as 3 centimeters in bone. This you can judge from the MR. We generally use a T1 image to judge the marrow margins, and we use T2 and PD images to judge the soft tissue extent. So it's okay to get marginal margin around neurovascular bundles, but a barrier like a physis or a growth plate or an articular surface is a thick barrier, and that's equivalent to a big margin in these areas where otherwise the margin physically looks small. So an adequate margin is something which would give us a low risk of local recurrence. And if you follow these principles, that you have one healthy muscle cover, a thick layer of fascia, articular surface, or covering everywhere around the tumor, and the tumor is not seen or not seen anywhere in the margin, then this is a acceptable margin. So like you can see here, the neurovascular bundle, especially with the posterior mass, can sometimes be very close. But at these times, if it peels off and falls off, this is something which we would accept if the patient has responded to the chemotherapy. Now, how do we treat an osteosarcoma can be illustrated by this example. You can see this is a 20-year-old female with a distal femur osteosarcoma. You can see this is the imaging. It was confirmed with biopsy, received the methotrexate-based protocol, and then went ahead and had a resection. We have resected the distal femur, put in a megaprosthesis. And what kind of function do you expect after a megaprosthesis? There has been a lot of doubt, there are a lot of myths which circulate. But in today's world, we know that it is compatible with excellent function. This particular girl wanted to be an air hostess. And the most difficult test was this. You can see from this video, you have to get down from the slide and get up immediately. She was able to pass that test and was then able to go on. She became an air hostess. She currently flies with Indigo. And nobody really knows that she's had treatment for, and she's a survivor for osteosarcoma. So the functional results today are expected to be very good. Now, distal femur is easier. For the proximal tibia, you have to reattach the extensor mechanism. I'm not going to go into the details, but it is very important that all these soft tissues be reattached back wherever it is possible, particularly important ligaments and tendons. So in the proximal tibia, if you do that, you end up with very good function there and no extensor lag. In the proximal femur, we try to reattach the abductors back. And that is the principle that you will put in a prosthesis, but it's very important to reconstruct these soft tissues as well. The implant longevity is important, and the myths associated with the megaprosthesis were all related to the survival of the megaprosthesis. Now, we know that there are only 2 factors which are important for the longevity of the prosthesis. The first one is the fact that a rotating hinge is far superior to a fixed hinge. And these are all hinged prostheses, and that's the reason why we worry about their failure rates. There are studies which have shown that a rotating hinge, and the second factor, which is an extracortical bridging, which means that you must get bone formation between the collar of the implant and the bone that effectively seals off the cement mantle and reduces the chance of aseptic loosening. So if you had a rotating hinge and if you had an extracortical bridging, then the chance of getting aseptic loosening is very small. So if you look at the long-term results of various studies, which you can see here, you can see that 10-year survivals of a megaprosthesis in the distal femur are very, very good. They are higher than 70%, and a proximal femur is higher than 80%. And even 15-year survivals, you can see here, are close to 63%. Even when revisions are required, you don't need to revise the entire prosthesis. You revise only the components which are worn off, which are generally the plastic components. So they are either the bushes or the tibial tray, and these are very easy to revise, and the patient goes back to good function almost immediately afterwards. Now, in children, the problems are all related to limb length discrepancy, which is expected to come when you resect the distal femur physis, which is an area of rapid growth. I'm not going to go into the details. For a long time, the kind of prosthesis which was used was an expandable prosthesis, what we call today as a minimally invasive expandable prosthesis was used, where you make a small incision, turn in a screw, which drives a worm gear mechanism to cause a lengthening. So this is done periodically, maybe every 6 months or maybe every 3 months in the rapid growth phase. You lengthen probably 1.5 centimeters at a time, and go on till the patient becomes correctly mature, and then replace this prosthesis with an adult kind of prosthesis. In today's world, you don't have to do this surgery, because every time you make an incision to lengthen the patient, there is a risk of causing an infection. There is a chance of getting stiffness. You have implants today which have a special gearbox built inside the implant, which is activated by a motor which is run by a magnetic field generated externally using this coil. So I'm going to show you this video where you can see the patient comes to the OPD, puts his leg into this copper coil, and then you switch on the current. And once the current is switched on, you can hear the gear running. And what we were doing manually with a screwdriver is now done automatically with this magnetic field. You can hear the gear system running. And for every 4 minutes in this magnetic field, you get 1 millimeter of expansion. So this can be done every time the patient comes in for a follow-up at 3 months. You don't have to lengthen too much at a time. There is no stiffness, and there is no risk of infection from repeated surgeries. These are expensive implants. These have to be imported, so not everybody can afford it. But for those who can afford it, these have made life much easier for these children. For those who can't afford these implants, we still have rotation plasty, as you know. In rotation plasty, you resect the tumor as usual, and you shorten the limb after rotating it externally. What this does is to bring the ankle at the level of the knee so that the ankle can work in the same axis of the knee. You then fit it with an external prosthesis, and this allows the patient to start ambulating as usual. Now, the advantage of a rotation plasty is that as you can keep the limb long to compensate for the limb length discrepancy which is expected, and therefore you don't need to do any future surgeries. There are no revisions required. It's a one-time operation, and all the changes which are done to the external prosthesis which is fitted. Besides, these children are actually able to run, jump, and participate in sports. So you'll see from a number of these videos, you'll see from this video that these patients can walk well. When they wear their trousers or their skirts, actually from outside it may be very difficult to tell that they've had a rotation plasty. It looks very disfiguring, but when covered it may not be so. You can see this patient walk. A number of studies have been done to find out whether there are any gait differences between a rotation plasty and a megaprosthesis, and they found that there is no difference. The oxygen consumption, the walking capability is exactly the same. In fact, most studies have said that rotation plasty patients have less pain, and they are able to participate in sports, they're able to run, they can rough use, important in the rural setting in India. And you can see even here, This particular patient was very fond of dancing, so he was actually able to give a stage performance. Children actually adapt very well to the prosthesis. Now, for diaphyseal defects, you can see here, for this is a high-grade surface osteosarcoma. You can do an intercalary resection. You can use extracorporeal radiation, where you radiate the bone which has been resected, remove the soft tissue, and you put it back like a graft. So like an allograft, this is an autograft which is recycled, and you put a fixation, and they heal up over time, as you can see in this case. Now, if the defect is long, as you can see in this particular case, then you combine it with a vascularized fibula. The advantage of combining a radiated bone with a vascularized fibula is that it heals quick, and the radiated bone also gives you the strength till the time this bone incorporates. This particular patient, you can see, is healed very well, and they end up with extremely good function. It's a biological reconstruction, so they're able to do everything. They're able to participate in sports. So even if the bone was not good enough to be recycled, that is radiated and put back, you can actually use an allograft. Like you can see in this case, the bone quality is not good. It was at risk of fracture. And we've actually used an allograft combined with a vascularized fibula. And this boy can actually play competitive cricket. He's a leg spinner, and he has been able to go back into sport. So unlike a prosthesis, biological reconstructions are allowed to load their leg, and they can participate in sport. So what are the outcomes with osteosarcoma? Osteosarcoma outcomes have been pretty good. Survivals are about 60 to 70% today with non-metastatic disease, between 20 and 30% with metastatic disease. Even if the relapse occurs, you can still remove the metastatic disease and still expect that the patient can survive. Most of the relapses come within the first 3 years, and actually 95% of relapse disease will happen in the first 5 years. So most patients who survive 5 years are going to end up being long-term survivors. Most of the failures will happen in the lung, and as long as the number of nodules are few and it can be resected, the patient still has a decent chance of survival. You can sometimes get a local recurrence in about 5% of the cases. Very often you may need an amputation, but if you pick up the local recurrence early and the location is such that you can get a margin, it may be possible to still do a limb-saving surgery. For metastatic disease, as I said, metastatectomy is possible, where you can remove that segment of the lung which has metastatic disease and still expect the patient to be a long-term survivor. I'm going to show you an example where these principles of treating osteosarcoma are shown. This is a patient who had an osteosarcoma at 10 years of age, underwent chemotherapy. She had a minimally invasive expandable prosthesis. She underwent numerous expansions over a period of time. You can see that screwdriver being used to turn the screw. After 5 years, she developed a large metastatic disease in the lung, which was resected. She became an adult. Her implant loosened. Then this in particular implant was again revised into a standard adult kind of an implant. She doesn't have any limb length discrepancy today. And today, many years after her disease, she is in her final year MBBS at the Grant Medical College and has virtually normal function. So the message from here is that we never ever give up in osteosarcoma. You just need one chance. Even metastatic disease can be cured. And it is important to take that chance and give them the full treatment so that these patients will become very useful citizens of the country and can make a career of their lives and lead normal lives. Thank you very much.
Thank you, sir, for that brilliant presentation. It was really mesmerizing. Amazing presentation.
Well, I hope it has answered all the questions and doubts on osteosarcoma.
Everything, sir. So I think everyone is like really stuck to the screen and they forgot to write their questions because no one would get time to even write their questions
Well,
because,
we can give them time now if somebody wants to ask a question.
yeah, let me see if there are any questions. I think, sir, there are no questions because maybe they may ask it later because
Okay.
the video gets archived and they'll be able to see the entire presentation again within 3 hours from now.
All right.
We can answer some of them there. But let me thank you once again, sir, for this amazing presentation. And I've heard this at many conferences, so I'm not new to your presentation, but every time you come with those images, it's really awesome to listen to you.
Well, the whole point of a lecture is to be able to see what you don't get to see from the books or the articles, and that's where that is important. So
Really
there's nothing
mesmerizing, I
more
would say.
teacher than real life cases.
Thank you so much, sir. And I'll get back to you if there are questions.
Okay. Okay.
Okay, thank you so much, sir. And I hope we'll do a couple more in the coming days.
Thank you, Hitesh.
Thank you very much, sir. I'll end the meeting.
Sure. Thank you.